Good morning, everyone. Thanks for coming back. We are here with me, the Desert Doula, Rachel Curtis, and Ask a Birth Professional. Today's guest actually used to be my next door neighbor when I lived in Oklahoma, so I have spent many hours talking to her about these things, and I know her passion intimately, and I'm really excited to be talking to her today and kind of sharing her knowledge with you. This is Liz Langthorne. She is a medical student. We're talking about some of the systemic challenges to breastfeeding. Liz has her Master of International Maternal Health, Child Health from Tulane University. The focus was on maternal mortality reduction. Prior to her master's, she was a certified birth doula. And after she got back to Oklahoma after studying, she worked for the Oklahoma State Department of Health. She was director for 3 injury prevention programs there. She's currently a member of the, a student member of the Academy of Breastfeeding Medicine, the American Academy of Family Medicine, and she is in her 4th year of medical school. So that is quite a diverse background. Obviously, the common thread is women's health. But yeah, so we're going to talk a little bit more about that. But first, Liz, you had told me that breastfeeding saves the lives of 20,000 women annually. So let's just start there. How?
Yeah. So it's about prevention. You know, when women breastfeed for a minimum of 6 months, it decreases their breast cancer risk, it decreases their ovarian cancer risk, it decreases their metabolic diseases risk like cardiovascular disease, diabetes. So when we talk about that 20,000 annually, it isn't that they had a baby, they breastfed, and they didn't die. It's when they had children, they breastfed for a minimum of 6 months, or they lactated. And then when they got older, they did not have these diseases, or they were less severe. So for example, when people lactate for a minimum of 6 months, they then are less likely to have aggressive early onset breast cancer. The ones that tend to kill women are when they're younger, they're aggressive. Now, they may still get breast cancer even though they breastfed, but it may be when they're postmenopausal, it may be a more indolent type of breast cancer. They're less likely to die from it. So, you know, it isn't that they stop dying in that year that they breastfed. It's a lifelong impact.
Still happy to have it.
Yeah. Well, and the other thing, ovarian cancer is another one that is frequently found extremely late and has a very high mortality. When women breastfeed, when people lactate for a minimum of 6 months, their risk of ovarian cancer decreases as well. And that one, since we don't have a good screening, we don't have a really great treatment. I mean, we can do surgery, we can do chemo and radiation, but it still has a pretty high mortality because it is found late. That one, if we can stop it from even happening, we have saved lives. So, I mean, it's a multi-organ benefit for breastfeeding, but it is dose response. You have to have that minimum of 6 months. And the more you do, the more up to 2 years, the more impact you have. At 2 years, the benefit plateaus. You don't get more benefit, but you get maximum benefit for breastfeeding for 2 years.
And I thought I saw something recently on endometrial cancer.
Yes, endometrial cancer and endometriosis. There are 2 different conditions that they aren't necessarily related. So endometriosis is when you have endometrial tissue implanted in your abdomen, parts of your body that aren't the uterus. And a lot of women have this. It's extremely painful. And the most recent research suggests that women who breastfeed, again, for that minimum of 6 months, are less likely to have endometriosis, which is kind of interesting because we think that starts, I mean, those abnormal implants could be as early as in utero for that woman. So we don't know how that works yet, but it was very interesting. But yes, endometrial cancer is not related to endometriosis, but same tissue. And yes, breastfeeding will reduce that risk as well.
Hooray! And I feel like this is not something that we talk so much about the benefits to baby, and I think sometimes we don't really highlight so much like all the wonderful things that breastfeeding can do. We focus on the breast milk and what's in the breast milk.
Right.
Much else going on. Okay, you had a quote, every system is perfectly designed to produce the result it achieves. and you used this in a presentation about breastfeeding. So explain to me why that's relevant.
Well, we have systems, whether they're intentionally designed or not, they have design and they have outcomes. And we have, particularly in Oklahoma, but globally, we have declining breastfeeding rates. We have a system that makes that possible. Whether we want that system to be that way, that's the outcome of the system that we have. And until we change that system, until we intentionally design it to have a different outcome, it's very difficult for any person to get their outcome, a different outcome. You know, that old saying of, we're going to do the same thing and expect a different outcome is the definition of insanity. Well, this is kind of the same thing. We can say, oh yeah, women should breastfeed and babies should be breastfed. But if we don't change that system that right now makes that difficult to impossible, we can talk all we want. Nothing's going to change. And so that's why we talk about the outcome is exactly what the program or the system is designed to make. So until we change that system, we can't change the outcome.
Right. Okay. So you're in medical school. How much time as a medical student do you spend learning lactation as a doctor?
Okay. So at my school, we get maybe 3 to 4 hours over 4 years. But when I say that 3 to 4 hours, that's, oh, hey, breastfeeding is good. Here's why we should breastfeed. Here are the statistics about breastfeeding. It's not about, here's the pathology of breastfeeding. Here are anatomical challenges to breastfeeding. Here's normal breastfeeding. Here's what you do to help breastfeeding. So there's a lot of didactic, and the research supports this. You know, the first major survey looking at breastfeeding education in medical school and residency was in 1995, and they found basically what little education there was didactic. It was not comprehensive, and it certainly wasn't hands-on. So graduating physicians didn't actually know what to do. They're like, yeah, breast is best. Great. What do I do? I don't know. And so that hasn't changed from 1995 when that research was done. And that was comprehensive throughout the US. We haven't had a single comprehensive survey since then, but we've had states have done it, schools have done it. Basically nothing's changed. So some schools get 0. You know, we get breast cancer. Oh yes, we get like 3 or 4 hours of breast cancer, but not breastfeeding, not lactation, not what is normal physiology and anatomy, what is abnormal physiology and anatomy, unless it's about breast cancer. More people are going to breastfeed than are going to have breast cancer, but we don't focus on that.
Well, I should hope more people are going to hopefully a lot more, you know, if we make progress. And yeah, you know, I mean, I'm a little lowly certified lactation counselor, and I had to go and learn stuff for like a week. I did like a 40-hour week, and I guess I am far more educated than a physician in how breastfeeding actually works.
Yeah, that's kind of a challenging, and a lot of doctors really hate that. They're like, I'm the expert. I went to medical school. But then when you come back, I did 40 hours worth of training. How many did you get? The research says you got at maximum 4. And that's between medical school, residency, and continuing medical education. 4 hours. As a CLC, you have 40. As an IBCLC, they have a minimum of 90. Yeah, there's a gulf of educational requirements on breastfeeding. And doctors just don't always realize that. And it can be a really sore point. So like, but I'm in medical school. I'm a doctor. I mean, you know what you're talking about.
Well, yeah, and I have to tell clients and students this. It's like, well, you know, your doctor, we really have no idea how much your doctor actually knows, because if they have an interest in it, they've kept up with it and learned, but they're not required to know any of what I just taught you in this little basic primer, actually. And you do run into that where it's like, you know, I teach and it's like breast is best. And, you know, I actually have tried to like reframe that terminology.
Yeah, it's not my favorite either, but it's the one that we hear so frequently. And that's what doctors are taught. Yeah, breast is best. Okay. How about, tell me what that means. What does that mean in a real functional level? What are you going to do to make that happen? And they just,
And women know, and I see they come to class while they're pregnant and they're all gung ho and they want to do it. And then, some of them I hear from after, and it's like they're having these issues. And, it's so hard to, first of all, I'm just a CLC, I'm still getting like clinical experience as I go. And it's like, there's like 3 people I know of that I can, text and try to find help for them, or a few places I can send them to. And it's sad that it's not their doctor. It should like go to your pediatrician or go to your doctor who you're going to be seeing anyway. And then they, it's really a scary position where they've committed to it and they want to do it. And then there's nobody there to help them.
Yeah. 80% of infants start with breast milk in hospital. And let's face it, most of our babies are born in hospital. So 80% of them start with human milk in hospital. But by day 7, we have lost up to 20% of them because they see their OB when they give birth, but then they don't see him necessarily until 6 weeks postpartum. Well, 6 weeks postpartum is a long time if you have a problem, right?
Yeah, you're done.
Yeah.
Your breastfeeding journey.
Yeah. So we lost them. And then, so they see their pediatrician maybe at 3 days. Great. Maybe some of the problems aren't really manifesting at that 3-day mark. And then they see them at 1 month or 2 months, maybe. And so you've got this huge window of missed opportunity because your first responders, first of all, aren't trained in breastfeeding. And when I say first responders, I mean your pediatrician, your OB, your family medicine doc, as our primary care providers for the breastfeeding dyad. They aren't being seen early enough. They aren't being seen by persons who have the education and training to identify potential challenges, that maybe show up early, really subtly, or maybe should have been discussed while pregnant. Here are your risk factors. You had difficulty breastfeeding the first time. Let's be intensive in treating it now and having a plan in place. We're not having those conversations. It usually becomes sort of crisis mode. Mom, baby's losing weight. The parent is in pain. Where do I go? Pediatrician is like, I don't know how to help you. Okay, so now we have a crisis and mom stops breastfeeding. So it's, that first couple of weeks can really make or break it. And we just don't have those first responders and in a position to really step in and provide the best support for mom.
There are no first responders, really. Yeah. And, I was kind of trumpeting all over this book I read. I don't know if you've read it yet, but it's called The Big Letdown by Kimberly Sellers.
Yeah.
And she makes that point, she has a whole chapter on it. And she says, we have, diagnoses for erectile dysfunction, but we do not have one for lactation dysfunction.
Right.
And
you know what that means.
System that our doctors don't really know, they're not taught anything about. So where are our priorities really? How are we supposed to help these women who want to do this and then have difficulties?
So when I talk to people, obviously I'm not a doctor yet, so I don't see patients yet. But when I talk to folks in my peer-to-peer work and in conversations like this and presentations, I talk about a lactation plan. I really encourage folks to, before the baby is born, identify who in their community is doing lactation support, who in their community is doing breastfeeding medicine. And there may not be anyone doing breastfeeding medicine in your area. There are only 200 breastfeeding medicine fellows globally. Okay, we have more neurosurgeons than we have breastfeeding medicine doctors. And let's face it, we need breastfeeding medicine doctors because a whole lot more people will breastfeed than we'll need neurosurgeons. Not to diss neurosurgeons, we need them. But when you're talking about a distribution in the population, we need to have people who understand normal and abnormal breastfeeding situations and can respond appropriately. So I encourage people to have a lactation plan. Who are you going to go see? What is it going to take? Who are you going to call on for support? That includes free breastfeeding support groups. That includes what lactation counselors are available in your area that are private, like one-on-one, and how much is that going to cost? So you aren't blindsided. Does your insurance cover it? The ACA requires a certain amount of coverage for lactation, but depending on your insurance, that may be at the level of an MD or a nurse practitioner or PA. Well, if they're not available in the community, now your insurance doesn't pay for that lactation support. So knowing that in advance, I just don't want families to be blindsided. If you have hypertension or diabetes during pregnancy or prior to pregnancy, know that that's a risk factor and have a plan in place. And that's where, having meeting up with your lactation counselors before you have the baby can be very helpful. Meeting with a breastfeeding medicine doctor before you have the baby can be very helpful. I know that's not always available, and we can talk about access and lack thereof and spend hours on that because it's so frustrating. But having a plan in place reduces sort of that crisis moment, because then okay, things aren't going well. This is who I'm going to go see.
Wow, that's great advice. And I always tell women in my classes to go check out the baby cafes now.
Yeah.
No problem, but I really like the idea of, we talk about birth plans a lot, but that it's really important to have a lactation plan, because that's what's going to go on. You lactate and breastfeed hopefully for a lot longer than you're actually birthing.
Yeah.
So talk to me about hypertension and diabetes. How does that increase? I did not know that. How does that increase risk factors?
So there's some very interesting research looking at the insulin resistance decreasing milk supply. So babies at breast, babies transferring milk, but because of that insulin resistance that mom has, maybe not as much milk is being made. And 50% of US women report concerns about inadequate milk. The bulk of them don't have inadequate milk, they have inadequate support. Okay, so they aren't even aware of what is normal. Okay, so, but there are women who are going to have inadequate milk because maybe they have insulin resistance, or maybe they have insufficient glandular tissue. Has anyone done an exam of their breasts to identify if they have insufficient glandular tissue? So, but in this one, we're talking specifically about gestational diabetes or chronic diabetes that existed prior to the pregnancy. That's a risk factor. What can you do? Have really excellent glycemic control. Work on, take medication that increases your insulin sensitivity. That can help. Is it a perfect fix? No, but the more we can help women recognize their risk factors, treat those risk factors, and recognize what is normal versus abnormal, we can support them better during this process.
Knowing what's going on and having a clue is just a huge part of, empowerment and being able to make your own decisions.
Yeah. And you expect your doctor to know this, to tell you, like, hey, you have risk factors. We should talk about that. We should have a plan. But if you've only got 0 to 4 hours of education as a physician yourself, you may not realize, the doctor may not realize that these
you might not bring it up, because why would you bring up a problem that you don't know how to help someone solve?
Right. And doctors are afraid of that. They don't want to ask questions for which they don't have a good answer. I mean, that's just human nature.
Sure. Yeah, absolutely. Okay, so let's circle back to, I find your trajectory just really fascinating, and I love it. So you were a doula, you were a certified doula, and now you are becoming a doctor. That is not a typical route. You see a lot of doulas go on to become midwives, and I think we've already covered a few of the reasons why you've chosen, but I'd like you to just kind of flesh out how you came to that and what kind of a doctor you're going to be, because you have a very specific target in mind, which is not why most people become doctors.
Yeah. So I became a birth doula after the birth of my first child, and I had I was in control. I did it in the hospital. I had an OB, but it was still, I had a lot of control over the situation, which I think was very unusual. I didn't actually have a doula. So became a birth doula, had some real challenging moments in hospital with clients. Unfortunately, with some pretty significant disrespect towards the laboring person from staff and from physicians. And that really turned me off the idea of medical school at the time. But then I went and got my master's of international maternal child health, which is a public health degree. And I specifically worked on maternal mortality and morbidity. And child and infant mortality is very intimately tied to that. I mean, when mothers die, babies die, particularly in low resource settings. So when I came back to Oklahoma and was working, I still wanted to work with women around their reproductive health and the fact that they should survive reproduction and their children should survive birth and in the first year of life. And I just found myself very sidelined with a master's of public health in this field. I couldn't change policies. I couldn't change provider practice. It was just very difficult for me to meet my professional goals the way I wanted to. So I finally made the leap, I guess, to do medical school, because with that MD, I have some more leverage with other MDs. You know, it's not perfect. You know, I still have some strikes against me. Still a woman doctor. And that's always the woman doctor. I'm not a doctor who's a woman. You know, I'm a woman doctor, which is a great handicap to have, let me tell you. But as a midwife, because I did very much look into going into midwifery, that is still so sidelined and marginalized, even as a nurse midwife, that I felt like I needed to have that MD to be even seen as an equal. I don't endorse that mindset, but you know, sometimes it is what it is. So, so medical school, and so specifically family medicine, because everyone's like, oh, you're going to go into OB, right? Because you love mamas and babies. I'm like, yeah, I love mamas and babies, but mamas are more than your uterus, you know? So for me, family medicine is an opportunity to work with the whole person, to work with the whole family. You know, from public health, we know that when we invest in women, their families prosper. When women thrive, their families thrive. And it isn't just, does their uterus thrive, or their breasts, or, you know, their vagina, the whole person. We're part of a person. And so working with women and their families is really critical to me. And I can do that as a family medicine doctor. As an OB, I work with women. I'm not really trained to work with infants. As a pediatrician, I'm trained to work with children, but not with their parents so much. And so breastfeeding is a dyad. It's a two-part organism, and both parts need help. And if I can only treat one part, then I'm not treating the dyad, and I'm not helping them in the most evidence-based, holistic manner that they deserve. So for me, family medicine is definitely the way to bring my public health work and my medical training together.
Wow, that is so cool. And I love that, because we actually, my last interviewee was a family medicine doctor. So we talked about just the kind of opportunities that provides. But he's also a DO, and I'm curious as to why, you know, that's a more holistic, he was explaining that's a more holistic kind of perspective and training. So why did you choose the MD versus the DO route?
I'm going to tell you at the most basic level, it was about convenience. I have an MD school 3 miles away because, you know, the next closest DO school is in Tulsa, which is a 2-hour drive. It was just too close to move, but too far to drive every day. And I had a child when I started medical school, and so my support is here. There are a lot of things that are really positive about the DO program, and I definitely plan to do some additional training so that I can bring in some of those skills that a DO would have. But no, it was not for any other reason than just convenience of being close.
Okay. That's fair enough. That's fair enough. Well, yeah, I mean, I just totally admire that decision. I remember you telling me about that and just being like, wow. Like, because I lived next to you when you were deciding to go to medical school, and I was like, that's really something. And, you know, that is a huge commitment and investment to take on, really, so that you can better serve women and families. And, you know, you're a trailblazer, and I think it's going to be, yeah, I think that's going to pay off huge, because I talk to my midwife friends and, you know, my nurse midwife friends, and they constantly have that struggle. They are not, you know, people don't really understand what they do. The doctors are kind of above them, and they have to refer to that relationship is very conflicted. You know, the nurses don't give them the same respect that they give the doctors. And Yeah, so I think that is going to pay off huge. So talk to me about um, the breastfeeding medicine doctors and the Academy of Breastfeeding Medicine. I think this is something I would like to talk about more with women and tell them to look for, and I want them asking their doctors about this. So what is that?
So the Academy of Breastfeeding Medicine is more than 20 years old, and it's a group of folks who back in the 90s said, we have nothing to offer breastfeeding families because we don't get trained. And this is a huge gap. And so a bunch of like-minded folks got together and made the Academy of Breastfeeding Medicine. The membership, I don't even remember how many people are members, certainly more than 200. And they're very international.
We're doctors. There's only 200 members, and how many doctors do we have?
Yeah, right. So the membership is maybe, I couldn't even guess right now, more than 500, I'm pretty certain. But like I said, the fellows, there's only about 200. Now, there are people who are practicing as breastfeeding medicine doctors who are not fellows. So I mean, when you add that number in, it gets a little bit bigger, but it's still not nearly enough compared to the population that we would serve. But they provide protocols for folks to share with physicians, to share with healthcare providers. So these are evidence-based protocols. You can just go look up Academy of Breastfeeding Medicine protocols. They have some on anesthesia for the parent, anesthesia for infants who are breastfeeding, pain during breastfeeding, breast pain, breast cancer, just a wide range of different protocols to help educate the patient and their providers, because as a family medicine doc, I might get some breastfeeding education as part of my training, but as an anesthesiologist, I'm going to get a big old fat zero, right? But yet every physician will see a person who is lactating at some point in their career, unless they are a urologist or a geriatrician. And they still may see someone who's got abnormal lactation, okay? Prolactinoma causes lactation in non-pregnant persons, and that can be older adults, that can be men too. Those are abnormal. But my point is, every physician will see someone who is lactating, and yet they will have zero education. And so many doctors don't know about the LactMed and Hale medication, which are two resources to review medication for people who are lactating. And so a lot of doctors are like, oh, I'm giving you an antibiotic, you have to stop breastfeeding. Well, that's A, not true, but B, means they are not familiar with the resources available to them to understand what medication absolutely is contraindicated during lactation. And there are some, but not nearly as many as women are told. So the Academy of Breastfeeding Medicine has curriculum requirements, guidelines, really, they're not requirements, but guidelines on this is what a physician should be taught as part of whatever they're training. It's sort of a minimum level of training so that they understand what lactation is and is not and how it will affect their particular practice. Because yeah, if I am a cardiologist and I see someone who's lactating and I don't know how prolactin acts on the medications that they give or the heart, then I'm not going to be able to provide the best quality of care. So that's one of the gaps that the Academy wants to fill in. It's also an opportunity to share best practice, to share knowledge. They have conferences twice a year. They have one in the US and one in Europe because they are truly international. And that's a great opportunity to get educated on the latest research. The Academy also has a journal that they publish. And I want to say it's just Breastfeeding Medicine, but now I've completely blanked on the name. So, these are just guidelines, protocols for physicians and for patients so that they can be educated and be on the same page. It can be a significant point of contention. So you have someone who's lactating and they don't want to stop, but the doctor doesn't know she doesn't have to stop. And now you've got this power struggle because the doctor's saying, well, I'm right, I'm the doctor. And the mom is saying, well, but I'm right because I'm breastfeeding. And so having those documents to put in each other's hands and say, okay, here's what the expert in breastfeeding and lactation is saying. Let's come to a decision together. mean, that's the best practice, the best kind of medicine for everybody involved. And so the Academy helps facilitate some of that.
Okay, and so women can look this stuff up
Oh yeah,
online?
oh yeah, it's free access. You know, you just look up the ABM, Academy of Breastfeeding Medicine protocols, and there's 24, I think, last I looked. And so they get updated, not like every year, but frequently, so that they are the most current information and research for certain topics.
Okay, and what does it mean then to be a breastfeeding medicine doctor?
Well, I get asked that a lot. And they're like, so how are you different than a lactation consultant? And I'm like, well, I'm a doctor. You know? So a lactation consultant or an IBCLC cannot diagnose. As a physician, I can diagnose. I can order tests. I can treat, whether that's surgery or some sort of procedure or having imaging done or fine needle aspiration or prescribing medication. You know, I can do assessment and evaluation for the mechanical aspect, but then I can take it that next step and say, okay, these are things that require medical intervention, if they do, and I can make that happen. As a lactation consultant, they can only say, well, here are the problems I see. You need to go see a doctor to get additional treatment. So I'm kind of a one-stop shop as a breastfeeding medicine doctor.
Well, and the doctor they go to may or not be able to provide those treatments.
Or may not know what's the appropriate response, you know. And it's a challenging situation because we don't have a lot of the basic science research for breastfeeding. I mean, there are things we don't know about breastfeeding. We know more about bovine breast milk or bovine lactation because that's an industry. People make money, but human milk, we don't know much. And there are folks who are doing research, and there's a really great lactational biologist, but her regular 9-to-5 job is for the dairy industry. So she fits in some on the side to do the human lactation part, but the bulk of the basic science is being done by formula companies and dairy companies. And so we don't know much. We certainly don't know enough to say unequivocally, you know, we understand breastfeeding. Even as a breastfeeding medicine doctor, I won't be able to say that because we just don't have the basic science.
Okay, and so to hang out breastfeeding medicine doctor on your shingle, you have to be what, a member of the Academy? Is that how that works?
Ideally, yes. Now, any doctor can say, hey, I'm a breastfeeding medicine doctor. So it's not like there are breastfeeding medicine police going around checking doctors and saying, hey, but that's where it behooves the patient to go in and say, okay, what's your training? What do you know? Where did you get your information? A lot of doctors get what I call old doctor's tales. They hear things about breastfeeding when they're on residency, and that becomes truth. Well, no, it's not. But they don't know that. They don't necessarily process that is not evidence-based. And so,
well, and there's so much study and research going on now and constantly new information coming out. So you cannot possibly rely on what you learned in your residency, even like 2 or 3 years ago. You really have to.
You shouldn't. But it is, I can't lie, it is challenging to stay ahead or even abreast, even slightly behind, you know. But yeah, but doctors need to recognize that about breastfeeding. And it's just not a mindset that's currently there. So as far as how you hang your shingle out, there's no requirement to be a member of the Academy, but patients should ask, are you a member? Are you trying to become a fellow? How many hours of education have you received? Because if they say, oh, well, I got it in residency, then the answer is no. They are not a breastfeeding medicine doctor. If they say, oh, I go to conference every year and I participate and I stay abreast, then I'm going to say, okay, you probably have a lot more clue. Mm-hmm. And sometimes it feels like I'm throwing doctors under the bus. There is so much information, just like you said. It is impossible to know everything about everything. You know, we are specialized, even as family medicine. There is a certain amount of specialization because I just can't know everything. So it isn't unreasonable to say that you need to see someone who's a specialist in breastfeeding. But doctors aren't evil when I say that. It's just they literally, unless they want to keep up with it, they can't. But then they need to recognize that and refer appropriately.
Mm-hmm. Mm-hmm. Okay, so and how, I mean, do women just need to like ask their doctors, or is there a list somewhere of doctors who?
Right now, there is not a list. Some doctors do advertise it, so you can, look for breastfeeding medicine doctor in your area. But I would just encourage people to ask point blank, hey, are you a member of the Academy of Breastfeeding Medicine? Because if you're going to see that person for breastfeeding support and they are not a member of the Academy of Breastfeeding Medicine, that doesn't make them not informed, but they should know about it. And if they don't, they need to hear those words. Because I meet a lot of doctors who've never heard about the Academy of Breastfeeding Medicine, and that includes pediatricians, family medicine docs, and obstetricians. So when patients ask that, maybe we can help spread that idea that this is something to look into.
Okay, so viewers, you have your marching orders. Go ask your doctors if they have heard of the Academy of Breastfeeding Medicine. And this is, that's how things like this happen, is people start talking about it. So, okay, well, Liz, that's all I've got. So unless there's anything you wanted to add, I think we'll probably sign off for today.
Yeah, just know your breastfeeding rights. Don't let anybody tell you you can't breastfeed. And if you're having difficulty, keep looking. Make sure you find the people in your community who know about breastfeeding and can support you. And that isn't always the most obvious person. Sometimes it's those free breastfeeding cafes or the CLCs, not just CLCs, but the CLCs who are working their tails off to get educated. And sometimes it might be a doctor, and hopefully that will spread so more doctors are in tune. But some of that's going to have to come from patients demanding it. So go forth and breastfeed and demand that they know what they're talking about.
Awesome. Liz, thank you so much. All right, everybody, I will see you next month. Thanks for tuning in. Bye.